right, can everybody hear me? Great. So I'd like to thank the organizers, especially my dear friend Sarah Reynolds, who recruited me to come and talk with all of you today. This might be the best turnout I've ever seen at one of these meetings, so kudos to you guys. This is awesome. So I am going to talk to you today about the cancer that most people have never heard of. These are called sarcomas. So the goals for my talk today basically want to convey to you how important it is to have a multidisciplinary team when we're dealing with rare cancers, particularly sarcomas. And then I'm going to walk you through what Sarah and I decided together would be called show and tell about the different types of treatment that we use for our patients. And I'll briefly touch on some future directions and areas of unmet need. So what are sarcomas? Well, sarcomas make up only 1% of all adult cancers and about 15% of pediatric cancers. And the thing that makes them so challenging is there are literally more and more different types of these things every single day. The pathologists get together in a room and come up with new things that we don't understand, and they have to teach us on the regular basis. But basically, these are cancers of bone or soft tissue, and we'll go through that in more detail, but they essentially can occur anywhere head to toe, and they occur in anybody from the very, very young to the very, very old. What's different about sarcomas compared to other types of cancer, when we think about metastasis, they almost always go to the lungs. They very, very rarely go to lymph nodes, which is weird, but they can go essentially anywhere. And most commonly, the story that I hear is somebody has a lump or a bump on their arm or their leg or on their trunk somewhere, and they assume that it's something perfectly fine. So now all of you are going to be feeling around for lumps and bumps, but the take-home rule is if it's bigger than a golf ball, even if it doesn't hurt, you want to get some sort of imaging. You want to look at it just to make sure that it is a cyst or it's a lipoma or it's one of these million other things that are way, way, way more common than what we're going to spend the next 15 minutes talking about today. Now, I will say that some sarcomas can occur inside the belly cavity, and those often don't present with a lump or a bump. They can actually present a sort of weight gain. Oh, I just felt like I was putting on some pounds. We had a guy that literally came in with this giant barrel of a belly, and he was super skinny everywhere else and was convinced it was just being in his mid-40s that was causing that. But you can see some pictures there of one of our surgeons pulling out a sarcoma from the belly, and then we'll talk a little bit more about the one in the arm up in the right corner. All right, so where do these things come from? So for those of you who treat leukemia or lymphoma, you might be familiar with this concept of blood cells coming from what we call a hematopoietic stem cell. And just like in the blood, those stem cells can turn into a bunch of different white blood cells, so lymphocytes or myeloid cells, macrophages, and so on. Well, it turns out that we also have something called mesenchymal stem cells, and so these cells can give rise to what we call our structural cells, the cells that give us bones and muscle and ligaments and tendons and all of those things that hold us together. And I tell my patients it's kind of like the gristle on the chicken breast when you pull the skin off. That's really what causes a sarcoma when you get genetic mistakes in one of those cells. And so this is just a summary of all the different things that come from mesenchymal stem cells, and this is a summary of how we name them. So we try really hard to figure out what cell they were supposed to be, and then if they get a cancer, or they become a sarcoma. So for example, a cancer of a fat cell that was supposed to be a fat cell anyway, is called a liposarcoma. Cancers of bone are osteosarcomas, and so on. One of the most common subtypes that we have is called a high-grade undifferentiated sarcoma. These actually we have a very difficult time finding a line of differentiation. And those hence the term undifferentiated, they really look like that primitive stem cell. So shown on the right, this is a chart sort of the most common ones that are out there. The most common one that you're likely to see at some point in your career could be a gastrointestinal stromal tumor or a GIST. The other ones really are quite rare, really with an incidence of only about 5,000 cases of soft tissue per year in the United States. From a genetic basis, what drives these tumors, the take home here is that our pediatric tumors often are driven by translocations. And so when we're diagnosing these, we'll try to do testing for that translocation, often called FISH. So you'll see that sometimes on the reports. And many of these sarcomas really only have one translocation that goes with them. It's what we call pathognomonic. So if you have a positive FISH for that, that diagnoses your sarcoma. But the more complex adult types, typically they look like a bomb went off. There's a lot of genetic complexity, and as opposed to some of our other cancers where we have nice molecular mutations that we have drugs to match with them, many of these sarcomas, unfortunately, have mistakes in major tumor suppressor genes, so P53, RB1, and to date at least, it's very difficult to drug those. All right, now we'll move into sarcoma show and tell, now that you've got the basics here. So this is a real patient of mine that I took care of back in Miami, where I was before Denver. He was a firefighter, 57 years old, and he was lifting something he probably shouldn't have been lifting at work, and felt pain in his right upper arm. So he went to occupational health, and they're like, oh, you tore your biceps. You have this giant swelling. Oh, you clearly have a hematoma, right? This is one of the top diagnoses that gets messed up for sarcoma all the time. So it got worse because it kept getting bigger, even though the injury had passed. And so he went to a general surgeon who decided he was going to go in to drain the hematoma. And then in the operating room discovered this was in fact a giant mass inside of his arm. And so he wound up coming to our clinic for treatment. So this is what's an MRI here, and what you can see on the left, this is a front view or the coronal view of the arm. You can recognize the upper arm bone or the humerus, and you see that giant bright white signal. That is his mass. This was a huge mass alongside his humerus, measuring about 15 centimeters. He had no other sites of disease. We did scans to look for metastasis at diagnosis, nothing there, so really it's a local problem. And we stuck a needle in this thing, and it turned out to be what's called a myxofibrosarcoma, which is a fairly descriptive term. Basically, bad jello-like substance is this myxoid material, but in any case, deriving ultimately from a cell that was supposed to be a tendon or a fibroblast at some point. So what do we do for this poor guy? Well, we take him to tumor board. So for those of you who are not familiar with tumor board, here's a picture of one of ours up in the left corner. So this is where we literally put about 30 different specialists in one room to review new patient cases. We have surgeons, and for sarcomas, again, we need lots of different surgeons, people who specialize in the chest, people who specialize in the belly, head and neck sometimes as well. So we get all of the experts together in one room. Radiation doctors, chemo doctors, we have a specialized radiologist whose job it is to look at the scans, particularly focused on MRI, which we use to look at soft tissue, pathologists to help us figure out what kind of sarcoma this is, social workers, psychologists, the works, plus our fabulous nurse navigators who make sure that all we need to take care of these patients is in our hands so we can make good decisions. And so we basically look at all of that data, the genetics, the path. We look at the patient factors. So Colorado's a massive state, right? So we have people that literally come from every little nook and cranny of the state, and they might not have a medical team for hours from where they live. This is a very common problem, and so when you're trying to organize complex care, that becomes a huge issue. So all of these things go into our decision making. So we have this fun app called the Sarculator. I did not make this app nor name it. Yeah, so the Europeans, who are geniuses, and they actually keep way better databases than we ever could in the United States. They essentially have collected years and years of data about patients with sarcomas and developed this app that will really help us estimate the chance of that patient's tumor coming back if you're able to do surgery and remove it completely. And so shown on the right is the stats for our guy, the firefighter guy. You plug in age, tumor size, the grade, which is how bizarre the tumor looks under the microscope, and then the subtype, and it spits out these numbers for overall survival risks and distant metastasis risks, which are what is shown at the bottom. So you can see this poor guy had essentially a 33% chance of developing spread, which is not curable in sarcoma, by the way, at 5 years. And a chance of being alive of only 60% at 5 years. So what do we do to try to help him? So for sarcoma, when in doubt, cut it out. That is always the case. If you can remove it with surgery, that's your best shot at cure. But during our tumor board, the surgeons are like, this thing is huge, it's stuck on everything, the blood vessels and the nerves right there, he needs an amputation. So, we didn't want to do that, and we knew he was going to need chemotherapy anyway to try to help lower that risk of metastasis down the road. Plus, if we gave him chemotherapy and it shrunk, maybe we might make his surgery a little bit easier. And then you'll hear a talk later from my colleague, Dr. Ryan Lanning, who's going to tell you all about radiation. But in a nutshell, if we do radiation to the sarcoma, you can improve the chance of it coming back at that site to basically 10% or less. And there is data that he'll go through, I'm sure, with you about whether it's better to do it before or after the surgery. But for this guy, we wanted to put everything we had to try to get him a limb-sparing option or allow him to keep his arm. So chemotherapy, yeah, for sarcoma, we're still using the same thing we developed about 40 years ago. Not so great, but basically the two big drugs we use are doxorubicin and ifosfamide. And this is not chemo light, this is pretty intensive stuff. So typically, if we're gonna do chemotherapy for our patients with the intent of improving survival and trying to cure these folks, it's 75 mg per meter squared plus 10 grams of ifosfamide per meter squared, and we bring people into the hospital for 5 days to give this therapy. Doxorubicin, as many of you know, can be associated with cardiotoxicity, so it's important for these folks that we are protecting their heart. We actually use Zenocard or dexrazoxane for sarcoma, which is not used typically in breast cancer and other types of cancers that commonly use this drugs, but it does greatly reduce the risk of cardiotoxicity, which is important because Dox is our best drug, and we don't want to, we ideally want to have it as an option later, even if we hit that magic 400 mg per meter squared mark. This is just some of the other toxicities. This is not easy for patients to go through. Significant risk of organ damage like kidney failure, volume overload, along with the cardiotoxicity that we talked about. People can get neurotoxicity with ifosfamide, which can range anything from just being pleasantly confused and sort of out of it like a bad hangover to seeing rabbits running around the corner of the room, the whole thing. Plus, there is an entire week of severe neutropenia, meaning like ANC of 0, requiring growth factors, risks of infections, all those things. So not exactly a walk in the park. But if you do it, you will provide about 10 to 15% improvement in overall survival and distant recurrence-free survival. In addition to this guy who got 6 rounds of chemo before his surgery plus radiation and actually was able to get to surgery and is now cured 5 years out with a functioning arm. All right, show and tell number 2, metastatic disease. This is not such a happy story, by the way, but this lady, 28 years old from New Mexico, history of melanoma as a child on her temple, very strange. She had surgery, no big deal, but then she was pregnant with twins and presented with a left breast mass. So everybody's thinking, oh, this is new breast cancer. But when they biopsied it, it actually was a spindle cell neoplasm, which is always suspicious for sarcoma or something in that continuum. It's based on how it looks under the microscope. They took that out, gave her some radiation, thought everything was good, but she developed new jaw pain and a mass in 2020. Took it out again, got chemotherapy and that same, the same chemo I just told you about, plus radiation, and she kept coming back. And so then they biopsied again, and they've got this differential, so 2 possibilities of either, is this spindle cell melanoma, which is a special type of melanoma, or is this a nerve sheath tumor, which is a high-grade nasty sarcoma, and they can look very, very similar. And when she got her PET scan, she had disease all over the place. Brace yourselves, glad breakfast is over. But this is this poor girl who literally just was getting eaten alive by this thing on her face. And the PET up in the right corner, everything that's bright white is potentially cancer. Apart from her brain, which you can see right there is this big chunky stuff, just showing how extensive this disease was. So what do we do? So in the setting of metastatic disease where you can't cut it out, you can't cure someone, we really want to know the goals of care. We want to understand, what do we need to do to get to surgery, if that's even possible, if we got a response, or are we really trying to prolong quality of life? Genetic sequencing. So in somebody like this where I don't have a clear sense what the diagnosis is, sometimes the genetic sequencing will help. And then we choose our treatments based on the subtypes, so I'll show you a summary of that. And of course, whenever you have a sarcoma, you want to think about clinical trials, particularly early where patients are in better shape. This is just a list of some of the other sarcoma regimens that we have in terms of chemotherapy, but the take home is that to date, nothing's been better than single agent doxorubicin. Insanely depressing, but it is what it is. But we will still go through these other lines of treatment. For targeted therapy, so the take home here is that There's a bunch of different types of sarcomas, and we have made progress in finding these ones that are driven by molecular drivers that we actually have drugs for. And we've actually been able to get approvals in a wicked rare disease for some of these drugs, such as pecoma, which is a peri-endothelial something neoplasm that literally had a phase 2 trial of about 50 patients, sorry for all you breast cancer people, and got approved because patients had such a good response. Anyway, so just to kind of move on for there, the other piece I'll just mention, so GIST is the other tumor that's driven by targeted therapy. So this is much more common. So you really want to identify GIST because it's a completely different paradigm. Chemotherapy does nothing, and we wind up using TKIs. So what happened to this girl? So sequencing was done, and she actually wound up having this weird fusion, PDGFRB. And what that told me is that she had this rare sarcoma called a DFSP, or dermatofibrosarcoma protuberans. And these can respond to imatinib. So we actually got her on imatinib, and she actually got a few years of stable disease. We wound up throwing in everolimus to cover some of her other genetic abnormalities. And I'll just give you a couple of examples where sequencing has changed the diagnosis. So leiomyosarcoma, which is an incurable cancer and poorly responds to chemo, turned out to be a GIST in my clinic when we did sequencing. So now she got imatinib and again is stable. And then I had a guy who had mesothelioma who actually wound up having an epithelioid sarcoma, and we were able to treat him as well. So sometimes we get lucky and we can actually use all the knowledge from our other cancer types for our own patients. All right, last but not least, let's talk about immunotherapy. So this is another one of my patients with a horrible disease called angiosarcoma. So this is a blood vessel cancer, and again, can essentially occur anywhere, pretty rare. The head and neck is common, and these tend to be driven by UV damage from sun exposure. The other one that's important to note is women that have had radiation for breast cancer. There's about a 1%, maybe probably a little bit less than 1% chance of developing a post-radiation blood vessel tumor on the breast. Really important. I had a woman be told by a mammogram tech that it was just a bruise, not to worry about it, and she came in with this giant purple horrible thing on her breast, so just to be aware. Anyways, this lady had one on her cheek, no other disease, and she went through 7 different treatments, clinical trials, targeted therapies, you name it. They cut her nose off, we did radiation, like horrible, horrible things. And so I put her on a clinical trial with a baby dose of an anti-CTLA-4 drug, which is similar to Yervoy or ipilimumab. And basically, she wound up having a very quick response, got to a complete response on biopsy, still not the prettiest thing, but essentially has been cured ever since then with a baby dose of immunotherapy. And it turns out cutaneous angio actually does have a pretty decent shot at response to these drugs. Now, the story's not so great for other treatments for other types of sarcomas with immunotherapy. We've been trying really hard. We've combined various things with checkpoint blockade to PD-1 and PD-L1 that you guys are familiar with, and really we're stuck at about a 20% response rate. We haven't yet found the magic partner to make immunotherapy work for everybody, but that's what we're doing a lot of research at in my lab and at the University of Colorado. So there's still hope. The other thing I'll just briefly mention is many of you might have heard of CAR T cells. So this is super cool cellular therapy for blood cancers. Well, little did we know, synovial sarcoma actually has been studied for cellular therapy directed against a marker called NY-ESO since the 1980s, 1990s. So this was even before the CAR T stuff. It's just taken a while to get there. So this is actually at review at the FDA right now. Basically, this is a cell therapy where, unlike CARs, the patient has to have the right tissue type. Okay, this requires a match between the construct that the company puts into the T cells that come out from the patient. It has to match. So that's only about 30% of the population. And then the tumors have to actually have the target. MAGE-A4 is this particular one, or NY-ESO. About 70%, but only synovial sarcoma and myxoid round cell liposarcomas, which, again, super, super rare. So we need more targets. We need more patients that we can use this therapy for. But the take home here is that if it worked, and if patients got a response, they could have long-term benefit from this. So still a lot of work to do, but exciting, and like I said, on the docket for approval. So in a nutshell, no two sarcomas or sarcoma patients are alike. Everybody's different, and it takes a village to take care of these patients. So, the take home is if you find a patient with sarcoma, they warrant at least one-time evaluation at a specialty high volume center. You're never gonna see these patients. And so to try to figure out the data, oh wait, there is no data. It's very, very, very limited compared to other tumor types. You just wanna have an opinion from folks who see these every single day. We're doing clinical trials. We're trying to do them earlier, but really it's about the subtypes. I think the more we try to put 100 different diseases into trials, we're really not gonna get anywhere, so we're trying to do that too. And then finally, really in an effort, particularly with immunotherapy, to learn from every patient, because we just don't have enough of them, and there's not enough interest from pharma and other companies to do these huge studies for our patients, so we need to make the most of everybody. With that, thank you. Feel free to email or tweet me, or I guess it's X now, so anyways, thank you all. Appreciate it.
Does anybody have any questions?
Yes. Yeah, so just to repeat the question, so how important is it to get that genetic testing early on before you start going down the road? How often do we actually get something that helps us? So certainly if the diagnosis is in question, and this is something where you want a special sarcoma pathologist looking at these slides from your patient with this tumor. So either that means sending it out to somewhere like Mayo Clinic or in Memorial Sloan Kettering, MD Anderson, big name sarcoma places, or they need to be evaluated at a sarcoma center where they actually have that intelligence in the tumor board and we can do all that work. The nasty truth is that, especially in metastatic disease, I still get the sequencing. If it's somebody who's just going straight to surgery and we know what the diagnosis is, I probably won't because it's not going to change my management. But for metastatic disease that's not curable, if I want to start looking for clinical trials, I'll typically do that testing at that point. Not all testing is created equal, and the sad thing is that for your standard sarcomas, it may only be about 10% of the time that you find something that's actionable. But if it's high tumor mutation burden, for example, which is only about 1% of sarcomas, but if you find that patient has a much better chance of responding to immunotherapy. And certainly, these one-off cases where you figure out it's a GIST and not a leiomyosarcoma, it's really transformative. So typically, as soon as I have a patient with metastatic disease, I'll get the sequencing. Yes?
How often are you seeing neurotoxicity or hypospadias? I just went to a center where we had a bad lot and we saw every patient.
Ooh.
So I'm just wondering, what does it look like in a not that situation?
Yeah, so the question is, how often do we see neurotoxicity for myphosphomide? So I have my voodoo that I kind of stole from MD Anderson, where they treated patients with the most, like they do this literally, the volume is huge. So there's a few little voodoo things we do that can kind of help. Part of the reason to split over 5 days is you can stop if you get into trouble. So if I have somebody who the nurses come in and they're like, hey, this person doesn't know their name or they don't know, like they're totally disoriented, we're gonna stop that day. And it usually will wash out in about 24 hours. The other thing we do is we're really aggressive with hydration, and I use something called albumin, which is basically a protein. Again, voodoo and no data proven, but I have had a lot less issues than I normally would have thought. Altitude matters here. So when I came from Miami, I felt like there were a few patients that I wouldn't have expected to have neurotoxicity, maybe have a little bit more of an issue here in Denver. And it's patient selection. If you bring somebody in who's in their 60s, you're gonna get some degree of neurotoxicity. So I dose reduce those patients, and I'm super, super, super careful, especially if their kidneys get stressed, you just stop, because otherwise you're gonna be way behind. And then those of you who don't know, there is the antidote, the magic methylene blue, where we give it to them, the patient turns blue, it's really creepy. But in theory, you can rescue people, although it's not 100% either. So I'd say probably in my patients about 10% of the time, but with all those caveats with the voodoo and patient selection.
Do you add B12 and folic acid with a prophylactic approach?
No, that's a great question. So about B12 or folic acid. So I will do, if somebody's had neurotoxicity, I'll add in thiamine, daily thiamine, which seems to help, kind of like the banana bag approach for chronic alcohol problems. That seems to help. I'll bump the albumin up to like 50 grams every dose, maybe run it slower. So that's the other trick, like instead of over 3 hours, you can run it over 4 hours, a little bit longer. And then there's also a strategy where you can do continuous infusion ifosfamide, which is basically a slow drip, 1 gram per meter squared over 24 hours that you can actually do outpatient. And that tends to have a little bit better neurotoxicity rates as well. Pain in the bum to do logistically, but we've done that before as well. All right. Thank you so much.